these older individuals to the clinic and then sit for hours and hours, and sometimes at 5 o'clock we tell them, sorry, we had too many antibodies, we couldn't do this. You have to come back tomorrow. So it's extremely important for us to reduce the transfusion dependence and see if we can improve hemoglobin so that the quality of their lives improve. And that's why clinical trials are being done. We don't have good therapy right now. Which brings me to now present to you this trial, which was reported in the ASH meeting earlier this month. This is the data from part 1 of the iMerge presented and described earlier to you by John. So the trial that is presented is efficacy and safety of imetelstat in transfusion-dependent, lower-risk, relapse refractory to ESAs. And basically, the background is, as I just explained to you, it's characterized by clonal myeloproliferation arising from malignant progenitor cell clones that have shorter telomeres and multiple clonal genetic abnormalities. They have shorter telomeres because they are dividing so rapidly. Telomerase activity and expression of human telomerase reverse transcriptase significantly increases in MDS and believed to play a critical role in dysregulated cell growth, enabling continued and uncontrolled proliferation of malignant progenitor cells. Higher telomerase activity and hTERT and shorter telomere length mean poor prognostic features for patients with lower risk MDS, leading to shorter survival. And as I just described, limited options exist. So this is, imetelstat is a first-in-class telomerase inhibitor that targets cells with short telomere lengths and active telomerase and has clinical activity in myeloid malignancies, as has been shown in the previous phase 1 trial. It binds to RNA template, preventing maintenance of telomeres. So this is not a small molecule, this is not a chemotherapy agent. Important for you to recognize what this is. And it targets the MDS clone with imetelstat with potential to improve outcomes. I just want to take a moment to tell you what I tell my patients. When I'm putting them on this trial, this is how I describe it to them, because patients like to see things or have something visual. And what I tell them is, imagine that you're going through a platform in a train station, and you've been given a ticket that can last many times. So every time you enter, the ticket conductor takes off a little piece. So every time you'll enter, this will happen, and then eventually the whole ticket is gone and you can't enter anymore. This is what happens to cells. Each time they divide, the telomere is shortened. Each time they're dividing, cell divides into, the telomere is shortened, divides into, and then finally there's no telomere left and the cell can't divide. That's what happens normally. Telomerase is maintaining this. As soon as this will tear off, then it rebuilds. The polymerase will come back and add the thing. So it's a very graphic way in which patients will always remember. When they come back for the imetelstat trial, they'll always tell me, Dr. Raza, that's the ticket. Where am I now? Because it explains to them what basically we are doing. This is the whole idea, that it's a genius thing. And of course, Elizabeth Blackburn and Carol Greider got the Nobel Prize for their discovery of this. We knew that there must be a mechanism like that in cells that get immortalized or extend their survival, but they're the ones who found it and showed it. The iMerge is an ongoing 2-part global phase 2-3 study of imetelstat in red cell transfusion-dependent ESA relapsed refractory lower-risk patients. Part 1 consists of an open-label single-arm design with monotherapy. Here we report safety and efficacy findings from 32 patients enrolled in Part 1. Subgroup analysis of patients naive to lenalidomide and hypomethylating agents treatment without deletion 5q will be presented. I'm just saying this here so that to prepare you that we will be presenting a sub-analysis which led to Part 2 of this phase 3. So the methods and eligibility involved adults with MDS, IPSS, low or intermediate 1 risk. They had to be transfusion dependent, defined as red cell transfusion requirements of more than 4 units over 2 months. ESA relapsed or refractory following at least 8 weeks of therapy with optimal doses of EPO or darbepoetin or a serum erythropoietin of more than 500. Any prior therapy, including lenalidomide or hypomethylating agents, was allowed, and patients with deletion 5q were allowed to enter irrespective of their prior treatment. So ECOG performance status had to be standard of 0 to 2 performance status. They had to have a normal ANC of over 1.5 and platelets of at least 75,000, independent of growth factors or transfusion support. And of course, their liver function and kidney functions had to be within range. The treatment consisted of imetelstat being administered as a 2-hour intravenous infusion every 4 weeks at a starting dose of 7.5. And of course, pre-medications included antihistamines and steroids. And dose escalation was permitted for insufficient response after 3 cycles. And this was done based on the previous trial in myeloid malignancies where the higher dose had produced myelosuppression, so the beginning dose was lower here. Supportive care, including transfusions and growth factors when clinically indicated, was permitted. Myeloid growth factors, not ESAs, of course. In terms of primary endpoint, it was rate of red cell transfusion independence lasting more than 56 days. The key secondary endpoints were safety, rate of more than 24-week transfusion independence, time of 2 and duration of transfusion independence, hematologic improvement, and rate of complete response and partial response per the International Working Group. So here are the results. Median age of these 32 patients was 68.5. 16 were males, 16 females. ECOG performance status was 0 to 1 for 91% of the patients, and 19 patients had low risk, while 13 had INT1. In terms of karyotypes, 50% had normal karyotypes, and the others had recurring abnormalities, which are known in MDS. And then WHO classification is described below. The results showed that baseline median transfusion burden for red cells was 6 units every 8 weeks.